Thanks very much for the honour of inviting me to give this lecture today, and thank you to you all for coming out on the first dark evening of the winter as it approaches. I will today give basically a talk which covers my career and give some insights into the things that I have learnt as an epidemiologist and a public health researcher across that time. This introductory slide is an important one in relation to the sort of overall talk, in that in Cambridge we are very privileged, but this is a photograph from Cambridge Evening News of a homelessness in Cambridge, and this is not a nice picture of a village, the village in which I live. It's actually a flood, it's a flash flood. And a 100-year-old neighbour also lived just there, and his house was flooded. It's just at the bottom of our own house, and this is our reading room in the village. And it was a flash flood quite a few years ago. And so I want to kind of emphasise the context of the work that we do as researchers, and particularly medical research. The overview of what I'm going to talk about is basically what have been the drivers of dementia research over the last decades, just a consideration of what dementia is, and what are representative populations, and why might we need that type of study, and what have these studies told us about dementia and Alzheimer's. I can only touch the surface of a 40-year career in dementia, but I hope that I can give you a flavour of it. How do these findings fit with the Alzheimer's disease narrative that we hear every day? And what's the role of early detection and diagnosis? And indeed, what's the role of inequalities and influences beyond individual choice? And then final reflections, which bring in the Sustainable Development Goals. And I hope that by the end of the talk, you will probably have a more nuanced version of what dementia research might entail and what the findings are to date. So the first thing to talk about, of course, is the size of the population and what's happened in to global populations over the years. And this is this extraordinary rise that we see in the modern era. And not surprisingly, this is a big challenge. And here we from 1950 to 2023, you can see the world's population is rising dramatically. But not only is it rising, it's rising because it's changing in terms of its age constitution. And what you can see here is the constitution of different ages. So here we have up to the present time, and then we go on into the projections for the future. And what you can see here is that the older age groups are expected to rise pretty substantially globally over the next decades. Unless, well, obviously COVID made a bit of a dent, but it's not substantial in terms of global populations. This means that we are living longer and we are dying at older ages. And this is, again, this is a demographic picture which gives you an idea of the age distribution of people at death. And you can see that it's the very substantial proportion of people are now dying in the older age groups. And this does matter. It matters for medical research because it means that we really need to know what's happening towards the tail end of life in the oldest age groups. And it will vary. So in the UK, it will vary. This is the Chief Medical Officer's report from 2025. And this is the age distribution as it is at present, or as census estimated, in different parts of the country. And what you can see here is that there are very different patterns if you go up the age groups here, up to 85. And so in cities, you tend to have younger age groups. And in rural areas, this is actually where I come from, North Norfolk, and this tend to have older populations. Actually, that's not new, because when I was growing up in North Norfolk on the coast, it was already substantially an older population. But it is very important for services. It's very important for understanding anything to do with health in populations. And even more so, the 85 plus population, which you can see from those death statistics, but this is a thinking into the future here, 2005, 2023, 2043, and the percentage of people aged 85 and over, and here are the percentages here, and you can see a huge change. So the proportion of the population aged 85 plus will increase, if things don't change dramatically, will increase very dramatically by the year of 2043. So we need to be ready for this, and I'm going to talk about the research which in a way was set up thinking about this many years ago. So coming back to dementia itself, it's a clinical syndrome linked to great societal concern at present, and it's largely because in Western societies it's about loss of function and a dependence on others. So that creates changes for the people around an individual living with dementia, but also for society as more generally, as numbers of people with dementia might increase. Dementia is effectively a syndrome, and it is a syndrome of cognitive decline, so mental decline, and a failing ability to cope with day-to-day function in a given environment. So from an epidemiological point of view, this is quite a challenge for definition, because I can imagine that you can think of environments in which the functioning in that environment will vary. So for younger people in a work environment, highly challenging work environment, the onset of early dementia, say, may manifest in a very different way from if you are quite frail and living at home and are 90, when many functions of life may have changed for you as an individual. So dementia syndrome is linked to neurobiological phenomena and often to general health and ill health. And there are really big changes in the way that's portrayed now compared to the past. This is King Lear and Cordelia from a 20th century, sort of 19th century picture, and here we have a picture from a charity which is portraying dementia as not something which is to be suffered, but to be embraced in a way and try to live life to the full if you have a diagnosis of dementia. Of course, the whole spectrum exists, and I'm sure many of you have experience of dementia in your families or in your loved ones, and you will have experienced an enormous range of different types of dementia progression from early stage to late stage and death. So epidemiology is all about trying to describe that. And the studies that I'm going to draw on to give you some snapshot results are mostly these, but not entirely. There's another study I will draw in as well. But these are the studies that I have been engaged in since 1985 in the Cambridge area and then in the national area. So epidemiology is the study of the distributions and determinants of disease and ill health in populations, and that can be across time as well. And there have been three major studies for me across my career, as well as being involved in a lot of other ones. The East Cambridgeshire study between 1985 and 1991, Cambridge City over 75 cohort 1985 onwards, and the cognitive function and aging studies from 1991 onwards. In fact, they started slightly earlier. But you can see, and you're all familiar with the Fens. So the first one was very much set in the Fens. The second one was very much set in Cambridge City, including all of the areas of the city. And that, of course, is a range of socioeconomic circumstances. And then the last one is across the nation, with sites across the nation. And they were set up, so this latter one was set up because in the 1980s, governments were concerned about aging populations and thought they ought to invest in it, in understanding, in research to understand aging populations. And there was a kind of consensus that it was important to look at cognition and disability or function. And so the cognitive function and aging studies were set up as a result of that, with epidemiologists from around the country. So these have involved researchers from all institutions in those areas, and the Cambridge ones, of course, involve people, and I'd like to pay tribute to Felicia Huppert and Jean Pakel, who were the co-investigators in both of these studies, and who often have now sadly died. But they were very instrumental in supporting us, kind of the collective, to do the studies in the population, because these are not, it's not for the faint-hearted to go out into the population and recruit individuals and try to maintain representative populations across time. So these studies, I'm not going to go into their methods, but they basically examined people in situ, in their homes, asked them loads of questions, these long-suffering, many people of different ages. The East Cambridgeshire study was women aged 70 to 79. The Cambridge City over 75 cohort was people aged over 75 in the city, and the cognitive function and aging studies were 65 plus. And these were standardized interviews administered by highly trained interviewers. In the first case, it was me, but for the second two studies, it was trained and recruited interviewers, sometimes wives of academics, often mostly women, who tirelessly went out and sought this very standardized information from individuals in order for us to be able to make or not a diagnosis of dementia, which can only be made, it has to be acquired cognitive deficit sufficient to interfere with day-to-day life. So we had to have all of those approaches standardized in order to create a diagnosis of dementia. But we measured a lot of the things associated with a diagnosis of dementia in populations. And that was the aim very much of this work. So in the first one, I basically went out and interviewed 365 women aged 70 to 79, and I was looking at all the elements that go into the diagnosis of dementia. You really have to know about somebody's life, as well as talking to somebody who knows them well. So I did that, this is one of the findings. The idea was to look, at the time people thought dementia was very separate from aging, or there was a bit of a debate about it. And this shows cognitive score, mini mental state score, which is now quite famous, and it shows you that the distribution of the scores, this is just a frequency histogram, and the size of the bars is the numbers of people in each of those categories. This scores 0 to 30, and you can see that it's pretty well, it's not exactly a normal distribution, but it's not far off it. And here you've got people who might receive a diagnosis of dementia, but actually you have a spectrum here. You do have a continuum. You don't have a binary distribution. And also you can see that the people in the older age groups, the 75 to 79, have a slightly lower distribution. So cross-sectionally, you can see that people in the older age groups are performing slightly less well than the people in the younger age group in that study. This study also looked at dementia diagnosis, and it was combined in a European, EU-funded consortium led from the Netherlands, from Erasmus. And this exercise brought together all of those people, all of those groups that had done population-based research. So the response rate in East Cambridgeshire was 90%. It was really high. And the studies were brought together to give a kind of combined assessment, a systematic assessment of the prevalence, that is the proportion of the population that might reach a diagnosis of dementia at any one time. And these were the countries that were represented, and it was a very powerful activity in that it produced these estimates, and these were used, and were used for decades actually. This is the prevalence of dementia across age. And here, this is the percentage. This is an algorithmic y-axis here, and you can see it's a straight line. So dementia syndrome is hugely associated with age. At the time, it was, there was a debate about age-dependent or age-associated. It doesn't really matter. It's just very, very strongly associated with age. So that is a binary, but I think I've shown you already that there's a continuum. So the binary is sort of superimposed on the continuum by the use of the standardized criteria for dementia that we were all using across these studies. So that combined analysis included the Cambridge City over 75 cohort, which was a huge proportion of the people aged 75 and over in Cambridge City. And that we were brought in, Jean Pekel and Felicia Huppert and I were brought into that study, which was conducted by Daniel O'Connor and Penny Pollitt, with a primary care physician and old age psychiatrist. We came in at not at the cross-sectional. I've presented the cross-sectional findings from the East Cambridgeshire study, but we were brought in at the follow-up stage. So we had this wonderful opportunity to do follow-up of this Cambridge City over 75 cohort. So the first part of that we did was a 2-year follow-up of the baseline. So we knew who had been diagnosed with dementia at the baseline, and this was over 2,500 people. And so we were able to look at the new incidence of dementia, but we were also able to look at cognitive change. So the change in the mini-mental state, again, this rather crude cognitive test, but we were able to look at change over time. And in the people who took part, there was a very good response rate of over 90% also. At baseline, and then we had an 80% at follow-up. Of course, there's quite a lot of death in 75 plus. But what you could see here is that there is a change in the cognition across time, across 2 years, and it's sort of around -1 for the mini-mental state. So the entire population is shifting down, although some people, of course, are doing very well. And that was, again, a bit of a heresy at the time, because people were thinking that this group who developed dementia were very, very different from everybody else. So there's a continuum of change, and some people slip off a bit more, in a more accelerated manner, into a more obvious dementia syndrome. How is cognition related to survival? Because that will affect how you look at change across time. And so I thought I would show you this slide, which is also from those relatively early days. But what you can see here is the levels of mini-mental state are associated with your survival probability over 10 years. So we followed people in the Cambridge City over 75 cohort up for many years. And this is the CFAS study actually, but the same thing is seen in the Cambridge City over 75 cohort. And you can see that at each level of mini-mental state, the lower scores, you have a lower survival. And this is very important because, of course, if you don't go out into the community and you don't look at people who are dying in between your phases of your interviews, you will misrepresent what's happening in the population. This is really important. Because if you do a volunteer cohort study and you don't visit people in their own home, but you just have the people who are coming back to you each time, you'll have a false view of what is actually happening in the population. And if you don't measure death, you don't know what's happening just before death as well. So one of the things that we have been able to do is to look at dementia before death as well, but I'm not presenting those results today. So I mentioned that it's a bit tricky, the sort of dementia diagnosis. I've shown you both the continuum and the binary type of results. And I wanted to share with you the challenge of diagnostic criteria. So there are lots of different, well, there's some different diagnostic criteria, and they do change across time for lots of medical conditions. And we tend to have a label. We say dementia, or we say asthma, or we say heart attack. But we don't necessarily think about, is that changing across time? Or have the accepted criteria changed? And of course they do change, and for epidemiology you have to know exactly how they change, including death-certification, because that changes as well. So you can't take these things as gospel truth. You need to try and think about what they really mean. So this was a very elegant study done by a colleague called Conjunti some time ago on a Canadian population study. There was a huge study in Canada, the Canadian Health Study on Aging, and he applied different criteria to the same population data. So there's a population study, lots of data from people aged 65 and over, and he operationalized different diagnostic criteria. So the International Classification of Diseases, CAMDEX is the one that generated from Cambridge, from Martin Roth, Felicia Huppert and colleagues, which was a very good interview schedule, which I used, and we used in the CFAS studies, and then clinical consensus, and then DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association. So this is WHO, this is American. And clinical consensus is just really what clinicians think. And you can see that there's actually, the overlap isn't great. And of course the overlap is mainly in the moderate to severe people who have moderate to severe dementia or living with moderate to severe dementia, and most of the disagreement will be on the detail of the mild to moderate, sort of the earliest part of the moderate. So this is a really quite a fuzzy area, and as epidemiologists we have to try to sort of fix on something, but we also have to be mindful that it's quite complicated. And this is an illustration of why it's so important to be aware of that complication. This is something done with a student of mine, Dan Davis, who's now a professor at UCL. And why do we emphasize the population, going out into the population so much? Epidemiology and public health, we tend to sort of say representation. We need to go out to the population. We need to understand what's happening in the true population and in communities. And be cautious about interpretation of what you might be hearing from a particular specialist. And this, or specialty, I should say. And so here, this is just to try to illustrate that point. You have the whole population, that's all of us out here living in the community alongside everybody else. But then we have these filters which take us through different types of services. And of course, you might actually go straight to a neurology service if you're doing private, and that's increasingly the case, so it's quite difficult for us all to track. However, in a system where primary care remains the gatekeeper, you go to primary care, lots of reasons why you might not or might go to primary care, so that's a filter there. And then, depending on what your characteristics are and what your complaints are or what your family's complaints are, you might be referred into different types of services or not referred anywhere at all. So the type of people who get referred to neurology tend to be younger and without any major illnesses. The people with psychiatry also tend to be a little bit younger, and also well, relatively fit, memory problems, say. And the people who go into secondary care will be older and have more conditions. And then you might have institutional care, which is what we called it at the time, now we call care setting, and then you might have palliative. And all of these, and people will be moving around these. So if you have an early onset dementia with psychiatric symptoms, you might start here and then move across here. So if you're a specialist working here, you'll see different ranges of ages and different characteristics. And if you think that this is dementia, you have the insight into dementia. It's not the whole picture. It's only one part of the picture. So our role as public health and epidemiology folk doing population studies is to try to piece together those jigsaws, because the different types of evidence is coming out of each of these, and they need to be integrated in order to understand how it fits into the whole population. So I wanted to show this as well. We have Shabina Hyatt in the audience here who did this work. This is the study, a different study, Epic Norfolk, which has been going on for several decades. And Shabina, as part of her PhD, also followed up people who had a diagnosis of dementia from that population, huge population study, started with 25,000 people. What she found was that if you look at different types of routine data, and these are the mental health data sets and hospital episode statistics and mortality, so death certification, that you get different people. So this is just to illustrate that point from the early years of Erkan Junti and the Canadian study, that you have to be careful about what you think is the gold standard. In fact, there is no gold standard. It's really, you just have to look and feel imperfectly and understand the imperfections of the data that are being collected. So while those studies have been going on, there's been an enormous blossoming, if you like, of different types of research, proteomics, so all the biological stuff from proteomics, genomics, omics in general. Imaging has advanced incredibly over this time, and also physiology, or what might have been called physiology, A.V. Hill, has advanced enormously as well. So all of these things have been going on in parallel. There was the decade of the brain that led to a lot of investment, and we've also seen a huge advance in our ability to analyze vast amounts of data. So all of these things have been applied to dementia because of the figures that I showed you about the rise in dementia with age. The politicians and the were concerned about the potential rise of the dementia syndrome in populations. And so the investment in the decade of the brain has had a very heavy focus on dementia and specific types of dementia in particular. So I've managed to get this far without talking Alzheimer's disease, but Alzheimer's disease is the term that you will have heard most in the media, and there's an awful lot of reporting about dementia and Alzheimer's specifically, and how to avoid it, how to detect it, how to early detect it, and almost every paper that comes out has a major headline coming out in the press because it clearly sells papers. I put a little quote here at the bottom. I don't know if you can see it, but Bateman, this is a very recent one, Nature 2025, just come out, said he's been running clinical trials related to Alzheimer's disease for nearly 20 years. From all I've seen, this is a very likely scenario. It'll be just like going to get your blood cholesterol checked and then being given statins if the levels are too high. And he's talking about the specific proteins in the blood which are disturbed in relation to what's happening in the brain. And Alzheimer's disease is generally characterized as plaques and tangles in the brain, and they're associated with two proteins in particular, amyloid and tau. And so there's been an enormous effort in that decade of the brain and since then, and in the imaging, to try to focus in on these particular proteins. So as epidemiologists, what we wanted to do was look at what was happening in the true populations. I'm just going to take you through findings from population studies in relation to that hypothesis that if you tackle a couple of proteins, you will really address the challenge of dementia and Alzheimer's disease in the population, which has been very much part of the narrative over the last decades. So the first thing is to look at the Alzheimer type changes in the brain in people who die with and without dementia. So this is from the Cambridge City over 75 cohort, and it shows you the findings at death in brain donation. So we had a brain donation program which was quite groundbreaking from the population. It shows you Braak stages which are effectively tangles, so they're more related to tau, and sera, as this is a particular plaques, which are more related to the amyloid. It's not quite as clear-cut as that, but that will kind of, as a characterization, it's not too bad. And these are standardized ways of looking at these from a neuropathology point of view, staging, using staging in the brain. And what you can see here is that people who die with and without dementia actually don't look that different. They are significantly different, but there's a huge overlap in the presence of these pathologies in the brain, whether or not you have dementia. And the same thing for vascular pathologies. So this was from the Cambridge City over 75 cohort. We were able also to look at these things in relation to age. So here you have the cognitive function and aging studies, which was the multi-site study of 60 people aged 65 and over. However, when you look at brain donation studies, it tends to be people in their 80s, because that's when people are dying, as you saw from the mortality numbers in the earlier slides. So here you can see the hippocampus, which is one kind of a memory part of the brain, and neocortex, which is the top part of the brain. And here you have atrophy, plaques, and tangles. So very much the Alzheimer pathologies in the different parts of the brain. And here we have age at death, and people who are dying with dementia and people who are dying without dementia. And the really striking thing about this is you can see that the patterns are different as you go up the age groups. So people without dementia here are beginning to look like people who die with dementia in terms of the pathology. This is very important in relation to thinking about drugs, because these people have got pathology, but they're not necessarily dying with dementia. So you might, if you have a drug for a particular pathology, you might end up medicating vast proportion of the population for no benefit. So this is very important type of finding. The other thing that I'm not showing the results in, well, I'm going to show the results from a combined analysis in a moment, is mixed pathology from this study in particular. And if you think about the amount of dementia that is accounted for by the pathologies, this analysis gives you some answers here. So a population attributable risk is trying to understand the proportion of the population, the proportion of dementia that is accounted for by a given pathology. And here you can see this is for the cognitive function and aging studies. We've got age, brain weight, Alzheimer's disease type pathologies, vascular pathologies, and other pathologies. And here is the population attributable risk. How much might be accounted for in the population by those pathologies? And what you can see here is that age and brain weight are around 20%, Alzheimer type pathologies around 20%, vascular pathologies around 20%, and mixed pathologies around 20%. This is very different from the media presentations that 60% of dementia in the population is attributed to Alzheimer's disease. So this is it's kind of important because it means that we need to not put all our eggs in one basket. And if you look beyond Alzheimer type pathologies in the brain to pathologies that had been previously very much disregarded, here's an analysis looking at the likelihood of dying with dementia with and without different types of pathologies. These are all sorts of little types of things like gliosis, which different types of pathologies in the brains. And what you can see here is in these very old populations that all of these things are above 1. And what that means is even accounting for the other pathologies, which is what the double dots are, even accounting for all these other pathologies, you can see that they're all above 1. So there's lots going on in our brains as we age, and they are associated with the presence of dementia. Not a one-to-one relationship, though. That's what's really important here to highlight. Education and dementia. So what about protection? So what is it that might be happening in these older populations who don't develop dementia when they have these pathologies? Well, there's a lot of interest in cognitive reserve, whether it be from kind of good early life, midlife, or late life. But this is an analysis from 3 population-based studies that have brain donation. And it shows you that there is some, apparently, at a group level, some protection from the expression of dementia according to the level of education that you have, from very little to larger amounts. And this is just one type of pathology. This is cortical plaques. And what you can see here is that for every level of the cortical plaque, none, mild, moderate, severe, you have a lower probability of having died with dementia if you're in the highest educational group. So that gives pause for thought and pause for thinking about how can we enhance the ability of populations to resist cognitive decline in the presence of a neuropathology. That's very different from a medication approach. I mentioned mixed pathology, and this is an analysis carried out by Richard Merrick along with American colleagues, and this is bringing together community-based brain donation studies. So we know whether people had dementia before they died or not, although in some cases you can't really tell, but that's a minority. And these studies were all put together, harmonized. There was a huge amount of work to do that. The neuropathology from the US and the UK in particular. And what you can see here, again, this is histograms with numbers of individuals in this case, and you can see dementia, no dementia missing. And these are the types of pathologies that you might see in the brain. We brought these, this is kind of a high-level description of the brain changes. And this is called an upset plot. And what you can see here, it looks a bit like a kind of a bead curtain, doesn't it? You can see the numbers who fit into each of these categories. So if you've got that, You've got one pathology, you've got the hierarch stage, and there's a tiny number of people, and actually all of those people had dementia. So if you read across here, you can see you get more and more mixed pathologies. And so these are community-based brain donation studies. It's not one pathology in the brain for most of the people who died with dementia in these studies, and they are community-based. So they are telling us something about real dementia in real populations. This is kind of very important and very much at odds with the type of media report. Again, this is from Nature just now, and this is presented as, you know, a stark binary. Here's a healthy so-called brain, and here's a brain with tau protein in it, which can now be imaged in the brain. It's ablaze with tau. However, what you saw from everything that I've shown you before is that actually it's a lot more complicated than that. That this is likely to be a very selective representation of what's happening in the population. As is this. Alzheimer's disease, this was from the web, Alzheimer's disease, normal aging. And I think I've shown you that normal aging actually includes these changes and other changes. This is very, very important. So the population evidence is that dementia in older populations is not as simple. There are blurred diagnostic and neuropathological states, and it's really quite difficult to distinguish between what you might call usual aging and dementia at the individual level. So what about, coming back to that education finding, what about risk and protection? So what's happening in the whole populations? And what are we likely to expect? What should we be expecting? So I'm going to move now sort of thinking about a bit more about risk. And so I've said dementia is not straightforward. And in fact, any geriatrician will tell you that they see cognitive decline in all sorts of conditions. I mean, dementia has many, many causes. And I've already mentioned the diagnostic criteria, but basically you can't say it's just happening in the brain. This is something which is happening across systems, and we need to understand better what the interactions of different systems are. But cognitive decline can happen in a multitude of conditions, including sort of cancer therapies and so on. But there are things that can potentially protect us. Epidemiological studies have followed people up over time, over decades, and they have published on the findings. And some of those media reports that I showed earlier are all about how can you avoid getting dementia or declining, your cognitive functions declining across time. Well, there have been exercises to synthesize all of the world's literature, or much of the world's literature as possible. And one of those exercises led to the claim that there might be 50% of dementia could be kind of avoided by eradicating these particular risk factors. That analysis by Barnes and Yaffe from the US didn't take into account the interaction between different risk factors. And so Sam Norton, who's now a professor at KCL, who was in our group at the time, worked out a method to try to look at the population attributable risk for different risk factors, but taking into account the interaction between them. And then to look at what might happen if you change those risk factors in populations in terms of the reduction of dementia. This is a reduction effectively across time, depending on whether you can reduce the risk factors and over what period. So this is a 10% reduction per decade and a 20% in these risk factors, and in with different demographic projections. And it looks pretty substantial. And another group took up this approach, and the Lancet Commission on Dementia has now published 3 times doing the same, sort of a similar thing, which is synthesizing the world's literature, working out how much a risk is associated with the future risk of dementia, and then trying to work out what might be the reduction in dementia if you tackled those risk factors. And it was very much looking at things that could be modified, so modifiable risk factors. And this is the figure that Jill Livingston and colleagues from UCL came up with, and Seb Walsh, who is here, I think, also contributed to this exercise in its most recent iteration, 2024. You may not be able to see exactly here, but we've got early life, midlife, and later life, and obviously our own results from our own cohort studies have contributed into this kind of analysis. And here you can see the population attributable risk is being estimated here from 7% of hearing loss, cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, excess alcohol, social isolation, air pollution, visual loss. This says late life, but actually we don't really know exactly what age, pinning it into life stages is quite hard. It depends entirely on what the cohort studies, the design of the cohort studies that have studied it. So that's a very powerful analysis globally and has been very influential in thinking about prevention. It's led to individualized risk reduction trials, about which I could talk a bit, but I'm going to talk a bit first about the risks. So I wanted to talk a bit about the vascular risks. So I've been kind of touching on the vascular risks in dementia. And we see vascular changes in almost everybody's brain by the time they get to mid-80s. And things have changed a lot in terms of vascular risk in the population over the last decades. And we've seen a reduction in SALT, this isn't a pretty old study, but a reduction in SALT, reduction in ischemic heart disease and stroke. And here's the reduction in SALT down here. This was just a nice kind of, it's not a causal analysis, it's just a kind of, it's a parallel analyses showing these things. But what we have seen, and the CMO's report this year has shown this as well, that you can see these huge reductions in cardiovascular disease, coronary heart disease and stroke over time. And of course, if that's associated with dementia, these things, stroke is definitely associated with dementia, then we would expect to see changes in the population in dementia as well. So we did study this. In the cognitive function and aging studies, we were able to do it in 3 sites, repeating the methods we'd used in around 1990, and we repeated the methods in 2010 to look at whether there was a difference in dementia in the 65 plus population in those localities. And what we found was that, yes, there was, for the prevalence of dementia, there was a dramatic reduction in the prevalence of dementia using the same diagnostic methods. Because as I mentioned, the diagnostic methods have changed across time. So you really need to be very careful about how you do these kinds of studies. We found it was similar for incidence. There was a reduction of around 20% in incidence as well. With these prevalence figures, in 2010, we estimated that there were over 200,000 fewer people living with dementia than there would have been had the blue prevalence applied. It's a really big difference. That's very different from the tsunami type or, this huge kind of concern about dementia increasing into the future. But it's a legitimate concern to be concerned about dementia increasing in the future if we have an aging population, if we don't see a continuation of these kinds of improvements. So that, a lot of the motivation for doing this study was because of the changes in the population that we'd seen for vascular disease, but also those cohorts and generations have experienced very different lives around the war with social care systems, with better earlier life, with better vascular care, with a lot more education. So coming back to education. This change, this reduction in the occurrence of dementia has been found in other Western countries as well. So France, US, Sweden, UK, France again. And you can see this is a hazard ratio here. Anything below 1 is a reduction in the occurrence, in the sort of new occurrence of dementias in these population studies across time. There aren't that many studies in the world that can look across generations, but these ones could, and they were brought together. The effect is found mainly in men rather than women, and that was the same in the UK, and there are all sorts of reasons why that might have been. However, in the UK, or in England, where we examined it, the reductions were seen mostly in those who were more advantaged. And it is the case, and the Chief Medical Officer's report has just shown this yet again, that almost every risk factor for dementia is hugely socially patterned. So this is diabetes, but you can see enormous geographical inequalities, but also inequalities by the local authority. So you have higher rates in those with more deprivation. The risk factors for stroke are also highly patterned, most deprived here, ischemic stroke here. Stroke itself is highly patterned, and the risk factors for stroke are also just look exactly the same. I could show you so many slides that look just the same. So socioeconomic disadvantage is hugely important, and it has been neglected in dementia research because of the focus on single proteins and their pathologies. I mentioned the fact that most dementia will be in the older population, in the oldest old, and here we have multi-morbidity, where we have more than 2 conditions, and this is again from the CMO report. And you can see again that for percentage multi-morbidity, that you have this gradient, and increasingly it's recognized that dementia is more common in people with multiple conditions. I wanted to show you something about gender. You won't be able to read this, but this is Richard's work as well. It's here. And this is gender, because I'm not really going to talk about gender much, but this was an analysis within the cognitive function and aging studies, which were enormously powerful. So the first round we had 18,000 people aged 65 plus, and the second round it was over 10,000. And it allows us to look at the biology, but also just simply the information from going out and seeing people in their own homes and interviewing them. And these are in different kind of domains: social context and mental health, biological resource, cognition, health expectancy, and dementia. And here we have no difference. It's the black here. Men have a possible favouring, as it were, women, possible, the purple, and then clear-cut significant differences between men and women. What you can see here is that green dominates the entire pattern, which means that on the whole men are doing significantly better, at least in the cognitive function and aging studies, which is a population representative study of England. Seb Walsh, who's here as well, as I've mentioned, has just published this with an MPhil student, and it's looking at trajectories at social class throughout the life course and doing a systematic review of all the evidence that they could lay their hands on in a systematic review, and looking at stable, sort of whether you're stable at low socioeconomic status, or whether you move socioeconomic status during your life course, or whether you're high. And on the whole, the results suggest this. A systematic review of 18 studies. There's a heterogeneity, of course. They're quite difficult to put together, these studies, so it was a great exercise. And low socioeconomic status across life consistently associated with increased risk of dementia. Upward social mobility mitigated it to some extent, and adult socioeconomic status partially mediated earlier life course. So it is really important to think about life course. And Seb and Richard and I worked on a paper for Lancet Neurology, and this was the figure that we came up with to try to think about what we need to do for dementia and neurological health as a whole. And this is also very much aligned with WHO work on life course neurological health. And so what we really wanted to capture in this is the stages at which you might be able to do different things to prevent what might be a bad neurological outcome. Because what we want is to have optimized our nervous systems, if you like, within our bodies, so that we enter older age in the most optimal state that we can, or try to do the best we can if it's not optimum, so that we can have reasonable outcomes. And then ideally, it's called compression of morbidity. You basically push ill health as far into later life as possible, and then we do have some evidence that you do die faster rather than going through having very chronic ill health. And there's a lot of evidence on socioeconomic status and extended ill health during the life lived, which is shorter. So you're not only dying at an earlier stage, but actually have ill health for longer. So trying to address that at an early stage in the life course is really important. I wanted to talk a bit about biomarkers very briefly. This again is a SEB analysis. This is from Epic Norfolk, this enormous study of midlife folk in Norfolk who've been followed up over time. And a lot of the risk factors for dementia were measured in that study. And it's possible to create a kind of risk factor score. A lot of the attention at the moment in terms of prevention is thinking about identifying people at high risk. And SEB did this analysis which looked at people who appear to be at high risk and then people who are not at high risk and what happens to them across time. And this interrogates the policy approach of trying to identify people who might be at high risk and focusing all your attention on that group. And it's very important to see here is that these, the incident cases of dementia are in red, so that's the distribution of the particular score of the risk factors across life. And the people who didn't develop dementia are shown here, their distribution. What you can see is that it's highly overlapping. So that if you only focused on the high-risk people, you'd identify a lot of people who don't develop dementia, so you waste a lot of resources, but you'd also miss the majority of people who develop dementia. And this was something that Jeffrey Rose taught in epidemiology courses, and it's really important. It's called the high risk. It's called the risk paradox, and it's a very important factor that most of the if you use risk to address disease, you will miss most people because by far the majority of the population are not at high risk, they're at a lower risk, but there are more people. So you get most of your cases from the medium to low to medium risk in the population here, this lot here. And you also misidentify a lot of people who wouldn't get the disease or the syndrome if you go for a high-risk approach. So for this, you can think about biomarkers as well, and polygenic risk scores. All of these things have this kind of problem inherent in them, that most of the cases in future will not come from that high-risk group, and you will mislabel people. So again, we need to be very careful about how we implement policies in this area, and I hope the government might listen, but I'm not sure that they would, because I think they're very keen on risk scores and AI and so on. There's also a factor that if you are looking at risk measurements, that they perform differently if you're in a high-risk setting compared to a low-risk setting. And I'll just give you the example of prostate cancer. So if you have a PSA that's high, in a urology clinic, it's much more likely to be associated with a prostate cancer than if you're in a primary care setting where there are no filters applied to getting there. In primary care, prostate-specific antigen does not perform well. You'll be very aware it's a very poor test for prostate cancer. So the same thing applies to all of these biomarkers that are being promoted at the moment for dementia or Alzheimer's disease, that in a memory clinic where you have the filters and you'll have a high proportion of people who actually have a condition here, and you won't have so many false positives here. This axis is false positives for these different markers in the blood, the biomarkers that are being promoted at the moment. If you do it in a primary care setting, you'll have vast numbers of false positives. And so this is just these are facts, a mathematical fact about test performance in different settings with different prevalence. And this is a very important factor in trying to interpret what's coming through to you all in the media and is being promoted by people from those specialist centres who don't have the same appreciation that the tests that they're keen on won't perform in the same way in different settings. So there are quite a lot of misleading tropes here that are dominant in our discourse. Biomarkers and testing early is a good thing, but for what? Over what timescale? What are the potential harms? Diagnosis is always good, not always necessarily. 60% of dementia is caused by Alzheimer's disease, and treatments of a single protein will impact dementia for society. I hope I've debunked some of those tropes. And we in public health, we talk about prevention approaches, primary prevention, sort of right upstream, secondary prevention, which is early detection and treatment, and tertiary is to reduce complications and make the course as comfortable as possible if it is very much set that way. And we are currently putting all our eggs into one basket. So, final reflections. It's an extremely complicated field. Earlier onset dementia isn't the same as late onset dementia. I hope I've shown that with the neuropathology. There's potential to do real harm in the way that we think about research from one setting and applying it to others. Whole societal change has occurred in dementia without us having a single drug for dementia across generations. This is very important to understand. So we need very careful policy development across the life course for maximum benefit, and it will also enhance healthy aging. We've neglected investment into what disorders are in populations because they change across time. And there's a disconnect between the policy and the reality. And I'll just give a side example of the genome measurement in neonates. I think it's being promoted as being potentially very good for subsequent health, but without an evidence base that I'm aware of for that claim. Addressing inequalities and gender variation is critical, and there is a real disconnect between the current medical research programs and sustainability, because a lot of the work that we're doing at the moment in our medical research, it's a very value for money and public health investment across the life course is very good. But if we put all our eggs in that secondary prevention basket, it's very costly in environmental terms and all other terms as well. So it doesn't fit with the Sustainable Development Goals or with addressing inequalities or within that. So I'd like to stop there, and I'll thank all our participants. This is hundreds of thousands of interviews across time, thousands of brain donations from dedicated families, and of course all my colleagues from a huge number of universities upon whom all of this has been totally dependent, and our funders. Thank you very much.